Thank you to those of you who have joined us for today's webinar, Building Blocks for a Successful, Sustainable Population Health Management Network. This is being produced in conjunction with HealthEC, and then also EHNAC, the Electronic Healthcare Network Accreditation Commission. I'm just going to walk through a little bit about the two speakers that we have today, provide a little bit more details on their bios, and then I'll turn it over to the speakers. Today we have Lee Barrett, who's Executive Director for EHNAC, the Electronic Healthcare Network Accreditation Commission. Mr. Barrett has a 10-year track record of leading healthcare professional service organizations, as well as 20 years of experience in senior management roles in payer and HIT solution organizations. He speaks nationally on a variety of health industry topics and is involved in a number of industry coalitions promoting the use and implementation of health IT, including both administrative, clinical transactions, exchange networks, population health, and cybersecurity, including compliance with federal healthcare compliance mandates. Mr. Barrett is also involved in development and proliferation of EHR systems and meaningful use across the National Health Information Network, including HIEs, ACOs, and other HIE exchange platforms. He can be reached at lbarrett@ehnac.org. Dr. Sanjay Seth has more than 20 years experience in healthcare industry. Earlier in his career, he's part of the turnaround team for the Interfaith Medical Center, Newark Beth Israel Hospital Center at Orange, and East Orange General Hospital, leading resolution and implementation of complex hospital and physician, clinical, financial, contractual, and compensation relationships. He's been organized two physician groups, leading to the formation of accountable care organizations under the MSSP initiative to manage ACO operations. In addition, he's transformed a multi-specialty physician group from 25 different entities to a cohesive group operating in a single tax entity. He's also established payer-supported virtual group patient-centered medical home program for over 15,000 lives, with care coordination technology to comply with the quality measures and utilization metrics. He holds a master's in health administration from Cornell University. Dr. Seth can be reached at sanjay.seth@healthec.com. I'm going to turn it over. Before I do that, though, I'd like to welcome everyone to submit their questions. You should see it on your GoToWebinar dashboard. Feel free to type in any questions that you may have or concerns. And we'll also be able to provide this complete webinar both on the HealthEC website and the EHNAC website right after it's completed. So we'll be taking that and submitting that too. So if you have any need for any of the files and the slides that are there, they'll be saved down there shortly. But with that, I'll turn over our first speaker, Lee Barrett, and he can walk you through the slides.
Thank you, Dave, and welcome everyone to this first in a three series of webinars that we're going to be having focusing on ACO and population health. With this, this whole series is, next slide, Dave. So this whole series is really going to be focused on really looking at risk and risk mitigation. We want to focus on as well the integration between the clinical network as well as the health information technology platform and the coordination between the coordination of care and the guidelines of compliance, including support of clinical data integration and risk management. We're going to be talking about the analytics, the various aspects around the granularity, as well as the ability to create various views of data, the cost drivers, how to scale across all the various platforms, as well as the organizational stakeholders, as well as patient and provider engagement. So these are all the areas that we want to be focusing on in this three-part series. Next slide, Dave. This first session and webinar really focusing on the strategies and the actionable steps that organizations can take to enable all the various industry stakeholders regarding some of the challenges that all of us are facing, not only today, but as well as what we're looking to do tomorrow. And with that, obviously there are a number of different initiatives that are going on with ONCs interoperability roadmap that they've laid out for the next 10 years. CMS and other organizations are as well laying out. EHI has laid out their roadmap. The WEDI has also laid out their roadmap. And so we're seeing, I think, the convergence of all these various initiatives as organizations are looking to implement the health information technology platform around population health and all the various models that are emerging. So with that, I'm going to turn this first section over to Dr. Sanjay Seth, who's going to take us through kind of the initially the essentials of the care team. Sanjay.
Thanks, Lee, and thanks, Dave. Welcome, everybody. We're going to start with what we define as the care team, the provider, the patient, the care coordination process, and the essential partners. The first and the foremost thing from the care team's perspective is the provider himself or herself. The provider needs to be engaged, they need to be informed, and they need to be incentivized. And without that, it is not possible to get the patient's cost, quality, and control under the umbrella. So the data that needs to be gathered needs to be done at the provider level. And this is the first critical step in trying to get the provider engaged. Then to define the provider's panel, it would be the second step where attribution is accurately done so that the right patient's data are linked to the right provider. And with that panel comes the embedded case managers. We have found that the embedded case manager is the most successful way of implementing a care coordination program. So a provider that's engaged, informed, and incentivized is the best provider. The same can be said about the patient. There needs to be an engaged patient, and the patient and the provider need to have a complete medical picture of their patients. And an engaged patient is, again, a critical step, because what we are talking about in population health is a behavior change, and you can't get to behavior change without having those two ingredients engaged. The third step is the care coordination process, and for that, the care coordination process needs to focus on ensuring access to care for the patients, and then trying to coordinate the care between all the providers, the specialists, and both institutional and community-based resources. And that would ensure that the care coordination is complete. What we think are the three most critical partners to this process are the skilled nursing facilities or the post-acute care providers, hospice, because they tend to have the highest cost patients in the terminal phase of their illness, and probably the most infrequently used service of home infusion. So gathering these three partners would form the first step as well. Next slide, please. Once the care team has been assembled and engaged, then we can start talking about the infrastructure that goes to support that care team. The first element is the organization and the governance. And the job of the organization, the leadership, and the governance is to eliminate barriers to care and to provide support to the practices. Barriers to care are typically started with communication channels. Once those channels are opened, barriers tend to come down. So creating the communication channels would be an essential step or essential function of the organization and the governance. The hierarchy of the same organization should be as narrow and short as possible to be able to be nimble in response to and adapt to new modes of delivering care. And we want the organization to view the patient as a whole rather than the traditional departmental handoffs we see in large organizations or hospitals. Of course, in every organization, peculiarities and personalities of providers and the leadership will determine how each of these programs are set up. Within the care management program, the first job is to really develop a comprehensive care plan for the patient. And that should include all the patient's identified problems and all their preventive care measures, their medication, all their acute and post-acute care that was provided in summaries from those organizations. Once the care plan is established, and it's this longitudinal care plan that can then help analyze and direct care. So assembling this care plan is the first step for a care management program. Assigning these patients to a care manager. There have been lots of organizations that have assembled a care management program centrally for the organization, and we have found that to be very ineffective only because the provider or the physician is not engaged in that process. Therefore, we recommend, and we've seen the impact of an embedded care manager. One quick nugget of information here is that in one of our organizations that we have been supporting, there was a transition from a centralized care management program to a embedded case management program, and that embedded care management program run over 9 months in 2014 produced a 26% reduction in cost and services for 186 patients, and there was a control group of 183 where care managers were centrally located, and for 186 patients embedded case management program was used. We've seen a 26% reduction. Of course, once the care managers are in place, we see the use of disease-based registries very important to support the care management efforts. And with that come the subject matter experts on disease to assist. And typically we find diabetes coordinators, nutritionists, physiologists, people with those kind of expertise helping the care managers with specific problems. And in the previous slide, we had mentioned that you pick post-acute care providers in hospice as well as home infusion. Those subject matter experts can also assist in the care management program. Of course, getting all of the patient's records into one location needs technology. And we'll talk a little more about technology in a bit, but data aggregation is the first step that the technology provider or the solution that the organization selects must provide. And that data aggregation includes claims data, clinical data, lab data, and data from HIEs or other sources that may provide the care manager a complete longitudinal picture of the patient. Once the data is aggregated, then we can talk about risk stratifying and analyzing that data to identify what we call the high risk and the rising risk. And without that, we are left with such a large population, unless somebody has unlimited resources, the ability to use and optimize the resources that each organization have, you need to give them a target. And those targets, a first place to start with those targets is to risk stratify the patients and give them practices and give them the patient list within the practices. Once the patients have been identified, then we can look at the patients with the gaps in care, and the gaps in care could be very basic in terms of identifying those gaps required for reporting measures or gaps based on evidence. And both those elements will automatically assist organizations in developing good quality metrics and reporting on them as well. Of course, once we have all this information on our fingertips, then we can help define the organizational strategy. And that is important because we need to pick a quarterback, and you need to have a quarterback for the practice. You need to have a quarterback for the organization. And at some levels, you might even have geographical or program-based quarterbacks or people who can spearhead the efforts for a subset of that population. That defines what sectors and what aspects of care does the organization need to focus on. Remember that focusing on everything at the same time will get you nowhere. Analysis paralysis is a very common effect we see in organizations that have been given raw data or unlimited slices of the data. Do not give them the ability to focus on any one thing. So those data analytics are used to help define the organizational strategy, and you can define the strategy for different quartiles in time. Next slide, please. As I said, we would need to see and use technology as assistant. Technology is not the solution. Technology is only a tool for the organization to achieve what they set out to get. The first steps that the technology solutions provider should give you is the ability to aggregate and normalize data. That is easier said than done, but it is a first critical step. To get credibility from the providers and the reporting entities or the accrediting bodies, that the data has been normalized so that there are benchmark and comparisons that can be made. That is a first step. The second step is to take all this data and auto-populate the disease registries. And you can create, or the technology provider should be able to offer a flexible disease registry program. Again, that would depend on the data that the analysis has shown. The third step would be to analyze the claims data and then incorporate into the claims data medication and lab data. And that is, again, not all technology providers see that as an essential step, but without medication and lab data, you're unable to really deliver evidence-based medicine or a clinical decision support system, because that data will drive those two processes. Once the data has been analyzed, then we can benchmark and do a peer comparison or a specialty-based comparison. Again, that's really important so that everybody understands where we are trying to get to and what is it that that benchmark reflects. Typically, benchmarks could be clinical data. You could benchmark against financial data. You could benchmark utilization data. And of course, if you were in an MSSP program or in any other form of shared savings program with a private payer, you would want to compare and demonstrate your progress as you go along. I can't stress enough the importance of stratifying the patients. And not everybody understands that this stratification does not have to be clinical only. It does not have to be based on one aspect of care or one data set. It needs to be done with a combined data set. And identifying patients who have a likelihood of using the emergency room over the next 6 months, or using the hospital inpatient services over the next 6 months, or requiring expensive procedures over the next year, only then can you strategize as an organization towards either the shared savings or a bundling program that you might be looking for. Once that patient population is stratified, then again we come back to defining gaps in care, both for reporting and for care. With this data, the technology provider should be able to offer assistance in minimizing duplication of testing, duplication of medication, drug-to-drug interactions, and making sure that there's a valid diagnosis for every evidence that the provider is gathering. Today's technology has given us the opportunity to do some revenue enhancing elements for providers through wellness visits, the annual wellness program with Medicare, the transition of care, and chronic care management. If we look at the Medicare population and Medicare's reports, over 80% of all the Medicare population would qualify for chronic care management. Admission rates for Medicare are in the 350 to 370 admissions per thousand, and if you take acute care and post-acute care admissions, that figure almost doubles. So if you can imagine, 60% of every Medicare patient population subset is going to get admitted either to an acute care facility or a post-acute care facility. Both the discharges from both those facilities are eligible for transition of care. Transition of care payments are over $200, and that gives an opportunity for the providers to not only enhance their revenues, but also we know that providers and patients participating in transition of care and chronic care management tend to utilize less expensive and unnecessary services. And they are both tools to engage the providers and the patients. In today's era of Facebook and Twitter and LinkedIn and smartphones, these tools must be a natural extension for both the patient and the provider. Next slide, please. So here are some of the provider strategies that an organization could undertake. As I said before, the most important thing to care coordination is improving the access to care. And access to care by patients could occur with the addition of mid-level providers, especially if you're looking at underserved populations or rural areas. They are very critical. Complementing the PCP, the primary care providers, with specialists is another option. In most states, telehealth is now an option, and specialists that are not available locally geographically could be accessed using telehealth services. Expanding office hours, very often underestimated and underlooked because we are so used to using urgent care in the emergency room. But expanding office hours to a couple of evenings a week or even one evening a week changes the use of the ER and urgent care. And you could develop a program that alternates evening hours within the organization so that somebody or the other within the organization is offering evening hours or hours on weekends, may not be Sunday, but certainly Saturdays. Urgent care costs are still at $160 to $200 a visit. And of course, emergency room visits are at least twice, if not thrice that. So office hour visits, one, they add dollars to the provider, and two, it is a cheaper form of delivering care to the patients. Within the providers, the shared savings incentives, having a good, well-articulated, well-defined shared savings program that incorporates mundane activities like attending meetings and attending seminars to very specific score guidelines on quality, cost, and utilization. You can create the right incentives for the providers. Of course, as we talked about before, the revenue enhancement strategies these days also offer a second opportunity to engage the provider. And finally, most providers have not revisited their workflow within their offices. And that service that an organization could offer of their providers is expensive, but has very meaningful impact on the physicians and their workflow within their offices. Again, technology could be a very good tool here to offer physicians a mobile engagement strategy, whether it is through alerting them of their admissions, their discharges, or their transfers, the ADT information coming out of the facilities, or for the truly engaged provider an opportunity to directly interact with patients at all times, including maybe refills for medications. Next slide, please. The care management. The first and foremost statement that I'd like to make here is please do not attempt to do everything for every patient and for every provider. It is a sure, a guaranteed failure. So therefore, we recommend that you develop these patient registries that are disease-based, or you could have alternative patient registries for evidence-based medicine. So you could target a particular testing or vaccination, pneumonia or flu vaccines. So these disease-based registries definitely can be used for care management. The targeted care management efforts will come from either these registries or from the embedded case manager program, and that we talk about next. And with these embedded models, you could supplement with some centralized functions, and those are disease experts, hospice, end-stage renal disease. Medicare has provided us with some benchmarks. End-stage renal disease patients typically typically spend over close to $100,000 a year, up to a maximum of $400,000 a year, compared to somewhere between $9,000 and $10,000 for the average population. And so developing a end-stage renal disease program is hugely critical to an organization's efforts to reduce cost and utilization. And end-stage renal disease programs could include chronic kidney disease and all its different tiers. That population typically will run somewhere between 0.75% to as much as 3% of your entire patient population. And dollars per patient, of course, as I said, very high. The centralized functions that support the social and community-based assistance, in developing that network of providers and resources patients that require assistance with nutrition or assistance with transportation. Those resources there are that need to be identified, be incorporated into your care management program, and offered as a resource to your care coordinators and physicians' offices. Those would be the critical points of care management that an organization should develop. Next slide, please. The final slide that I'm going to talk about is selecting the right partners. Remember, every partner needs to have a dual purpose to address both the cost and quality, and to provide specific support to an identified or targeted patient population. The second partner topic that I'd like to address is the dually eligible patient population. This is Medicare and Medicaid. They tend to have twice the average cost compared to the normal population. And again, there are a lot of social issues affecting these patients. So having the right community resources for this dually eligible population is important. It brings back another point where sometimes you need to do a segmentation of the population based on zip code analysis or on where they live, because they tend to aggregate in the areas where there's an abundance of low-income housing. So you need to identify these communities and identify the resources within these communities. The church groups and the food banks are very, very important resources in these communities, and will offer not only those services but a whole range of people volunteering their efforts for the community and within those organizations. And with specific focus on medication, transportation, and nutrition, because all affect access and ability to handle illnesses. With respect to medication, all the major pharmaceutical retail pharmacies, CVS, Walgreens, Rite Aid, are all offering services to the ACO population or organizations, whether it be in form of minute clinics or education material. They offer assistance with home deliveries. There are organizations that you should reach out to, and be assured that both cost quality are addressed, because sometimes they are, of course, retail businesses and looking for the bottom line. You need to pay attention to that. Of course, with the recent changes in reimbursement, remote monitoring, both using Bluetooth technology or telehealth, are both aspects that could become an integral part of any organization strategy, both to engage the provider and the patient. And technology today, Fitbit devices, glucometers, sphygmomanometers, all of them are available as remotely connected devices feeding into a centralized system. So these would be sort of benchmarks to select your partners, both in the community and within your provider community. I'm going to turn the presentation back to Lee, who will take you to the second half of our seminar, which covers how to achieve a compliant and secure platform, the process and benefits of getting accredited, and a little more on population health management strategies, including what ACOs could include for criteria for patient engagement. Lee?
Thank you, Dr. Seth. Thanks for taking us through the kind of the stakeholder key essentials and some of the strategies that organizations can look to deploy. So as Dr. Seth mentioned, I'm going to kind of take a slightly different approach here to start looking at the areas of kind of risk mitigation and third-party review that at the various networks want to, I think, engage in, especially as we start to look at the areas of privacy, security, confidentiality, and how patient data is exchanged across these various platforms. And so, you know, as we look at this, the key is really securing all these various connection points, and we've got a lot of various exchange points that are taking place. The aspect of using the direct protocol for authenticating between various connection points and stakeholders, the ability to encrypt data between any of the secure messaging that's going on, either clinical or administrative, between various stakeholders is a critical component here. The whole aspect of stakeholder trust, and this is really what this is all about, and determining and trying to mitigate the risk of a breach or an incident, cybersecurity, of the whole hacking side of this. And in fact, a very interesting statistic is that just in 2015 alone, there have been close to 100 million identity or theft or breach incidents that have occurred. That's just up until basically through April of 2015. That compares to 8 million total that occurred in 2014. So as you start to look at, you know, the anthems, the premiers, other types of breaches that and incidents that have occurred, the need to assure compliance with HIPAA, ITEC, the Omnibus Rule, the Office for Civil Rights, et cetera, becomes absolutely critical as organizations look at their overall strategies. The patient consent process is also very important for opt-in, opt-out, and being able to secure all these various portals for where information is exchanged. And also looking at the aspects then of sustainability and transition planning of the ACO and population health networks. And we'll talk more about that as I go into some of the examples of some of the criteria that we have included into the accreditation program that we've developed for ACO/population health networks. Next slide, Dave. So as we look at this, really this comes down to looking at achieving the appropriate balance between cost, trust, value, and as you're looking at this between ONC, the Office of National Coordinator, and CMS, the issue here is on the cost side of the equation, looks at, you know, the standards and the ability to use as many standards as we possibly can in the environment that have been developed that deal with some of the core interoperability issues, really encouraging business practices and policies to be used as much as possible to allow for that information flow between patients and patient care, and as well being able to have a really important HIE program and having the infrastructure there, and then managing that and balancing that against kind of the value side of here, the whole payment side, the meaningful use 2, now meaningful use 3, and to get the scalability and the adoption across the entire continuum. And then the whole stakeholder trust side. So you've got value and trust on one side of this continuum, cost on the other, and it's a matter of managing these as we look at shared savings in the various networks and models that are out there. Next slide, Dave. So as we start to, you know, look at really the enablement health information technology and the enablement of all the various ACO population health operations side, you've got obviously we talked about the standards, you know, data liquidity and the fluidity across the analytics, the trending across all this, and the ability to, as Dr. Seth was talking about, the whole stratification aspects and being able to get at a granular level the various aspects and views that organizations are looking for. And then patient engagement, whether it's mobile through mobile devices or digital health, and you get kind of the whole telehealth side of this, which also plays a role, are all important components. As you look at on the right-hand side of the slide, all the various stakeholders as part of kind of the interoperability platform and the various connection points, you've got both, the state, you've got individual registries, the hospitals, the HIEs, the practices themselves, the labs, pharma also in here, and how they're connecting between these various points and authenticating between all those various connection points as well. Down on the left-hand side, you've got, the converting paper-based workflows, the clinical messaging exchange, the portal side, and you've got, patient, provider, other types of portals and various views, and then the whole collaborative care, which is a whole, basically integrating the community-wide data exchange, the analytics, as well as the overall care coordination that becomes part of the enablement of the ACO operations. Next slide, Dave. So as we look at this and we look at the view and how the ACO's population health is evolving here, you take it, look at it from everywhere from the predictive modeling and risk side, the clinical performance, the financial performance, the quality reporting, all the interventions, the alerts, how that's playing out in the M-Mobile as well as the portal environment, the patient interactions and collaboration, and kind of the overall gaps in care, where those are and how to mitigate some of those gaps, and then the overall care plan and how that gets implemented and executed are all part of kind of the view and how this is actually evolving over a period of time here. Next slide. So then if you start to take this down and break it down, this is a kind of a busy slide, but what it does is it certainly looks at the value proposition here, and you look at it from the standpoint of the various entities or stakeholders that are part of this, whether or not it's the health plan, you've got the claims, the billing, the pricing side of that, the ACO entities, which includes the labs, the medications, the specialists of the EMR side. You have other third parties with patient billing, the clearinghouses, the PBMs, the health information exchanges, the various tools that are available for care management, the portals, the various incentives and notifications, population management, which is all about the data, the various dashboard views, the portal side of that, and then the other aspects that are part of this, the data aggregation and integration, the storage and the various repositories that are part of that, and then how that information is actually delivered. And so this kind of gives you a complete holistic view, I think, of all the various integrated value proposition that we're heading towards, I think, over a period of time, and it's evolving very, very quickly. Next slide, Dave. So as we start to look at this, and we talk about the environment and how the environment is evolving very quickly. The whole shared savings models are in fact continuing to evolve and to change. The whole aspect here of having third-party review of the infrastructure, the various connection points, the stakeholders, and becomes absolutely critical. And so EHNAC, many of you may or may not be aware of EHNAC's background. We were founded in 95 as a 501c6 not-for-profit accreditation organization. We're federally recognized as a standards development organization, and what that means to you is that EHNAC, when they develop their programs, is a very transparent process, allowing, as we develop any of our programs, to have all that information available to the industry to provide input into the process as any of the programs are developed. There are over 100 accredited organizations that are under the 14 different accreditation programs that EHNAC has. States like Maryland, New Jersey, Texas, Minnesota, Utah have various of our programs that they've implemented in those states and legislated. We've got a commission board of 14 industry stakeholders from both public and private sector that make up that composition. And really it's all about peer evaluation and looking at kind of quality service innovation, cooperation amongst all these various entities as we look to create our programs and to put together a bar. And really it's all about creating an open competition. We created an accountable care population health accreditation program and launched it in January 2015. So I'm going to talk for a few minutes about what that program entails and the areas that we're focused on. And again, it's all about risk mitigation and providing for stakeholder trust. Next slide, Dave. So the criteria, some of the criteria samples and that we have here, and I do want to say that HealthEC, we created two of these programs. One is an outsourced accreditation program for ACO population health, and the other is an ACO accreditation program, again, for the actual networks themselves. HealthEC was one of our beta organizations and achieved accreditation as one of the vendors and the service providers that provide the networks, the infrastructure to organizations. And so very significant milestone for organizations like that to achieve, who are providing services to ACOs and population health networks. And we created the same accreditation for the networks themselves, so that, again, it's all about providing stakeholder trust and mitigating the risk of breach or incident, and providing kind of the authentication as well as the encryption between all those various connection points. So this is one example where we focused on privacy and confidentiality. And again, all of our accreditation programs are compliant with HIPAA, HITECH, the Omnibus Rule, and incorporate the Office for Civil Rights protocol, so that we've aligned as much as possible with the OCR protocol with all of our criteria to, again, be in position if any one of these networks were to, in fact, be selected by OCR for an audit, that those organizations would have the appropriate documentation to provide to OCR. So this first set of baseline criteria, focuses on encryption and authentication and really using the direct protocol and having documented plans for the notification. Again, this aligns with the Office for Civil Rights that requires that any type of breach or notification of over 500 individuals has to be reported to OCR, and then there's a whole complaint notification process as well that anyone could make. So this provides for having the documentation for organizations to be able to address any specific issues. And lastly is really all about providing an annual risk assessment that organizations need to go through. Next slide, Dave. Additionally, what we focused on is the introduction to candidate environment and trading partner agreements. So organizations have to have formal operating agreements, participating agreements. They have to list the participants and the governing body, so that it's, again, we're into creating transparency and assuring that all the appropriate documentation is in place. Entities must have the ability to have periodic audits to monitor compliance with all the various federal as well as state privacy laws, because we're finding that even with the states themselves, the attorney generals are taking a very much more in-depth view of organizations, even perhaps than at the federal level. So we're all about having organizations having the appropriate guidelines and documentation to address any specific requests that would be made. Next slide, Dave. Some additional examples here about sustainability and termination of operations. And again, part of this goes down to if an organization doesn't, for whatever reason, is not able to create a sustainable operation, it has to go through some type of transition to another organization, we've got that organization must have a plan documented and in place as to how they would execute that. And so there has to be a whole formal plan and execution strategy on transitioning all of the services to another organization. This is for all the patients, all the various stakeholders that are part of that network. Next slide, Dave. So lastly, the whole aspect of patient and provider engagement. And again, you've got the whole patient consent, opt-in, opt-out, and being able to make that as easy as possible for patients to be able to view and contribute and to manage their personal health record to some degree. And the whole quality measurement side of this, which we all know is part of the whole plan here for MMSP is critical as far as all those stakeholder measures. So all of these are some of the samples of the types of criteria that the networks have to go through, as well as the service providers that are providing the backbone and the infrastructure to population health as well as ACOs. Next slide, Dave. So that kind of gives you a pretty good overview of some of the strategies that Dr. Seth has gone through from some of the essentials, some of the overall strategies there, and I've taken you through, hey, here's a third-party entity and that can go through and some of the things that you need to be thinking about as whether or not you're providers of these services to ACOs and population health platforms, or you're the network itself and providing those services to the various stakeholders. So what we're going to do is, at this point, I'm going to turn it back to Dave Anderson. And if you have any questions for Dr. Seth or myself, please do type them in, and we will get to your questions. And so, Dave, let me turn it back to you.
Great, great. Well, thank you. Well, the first question is actually just accessing the slides. We'll make the slides and the entire recording available right after this session. I believe we can also send this out to you as well. So we'll be sure to do that. I know there was some audio difficulties around slide 8 or 9. So if there were specific questions around that, we're happy to answer that. But there is one question here for Dr. Seth. I'll just jump into it here. What challenges are you seeing across population health networks regarding how they're handling the organizational structure and governance issues? Dr. Seth, if you could help us out with that one.
Some of the things that we are finding is the ability of the organizations to difficulty in setting up committees to help organize both the communication and the topics that need to be discussed. So pay particularly close attention to forming a committee that addresses the quality issues, so that it's led by perhaps respected community-based or voluntary physicians, in addition to the appointed physicians or employed physicians by an organization, to balance the representation a little better. We find that over time it is that committee that plays the most important role, because not only does it impact on real quality of care, but also indirectly impacts compensation and distribution of bonuses. So the quality committee one should pay close attention to. The other committee that doesn't typically last or functions through the entirety of the organization's life, but a compensation committee that sort of helps disseminate the information on how bonus structures or incentives are paid out. On that committee, very important to definitely give unequal weightage to the PCPs, but at the same time not to ignore specialists. And what we have seen, splits of 80-20, 75-25, 70-30 even in favor of the PCPs works as well. But if you're an organization that's heavily weighted with specialists and trying to motivate all of them with a very small percentage would become a challenge. So those two committees we find are critical. But I hope that answers the question, whoever asked that question.
Okay. Well, great. Well, thank you. And Lee, I did mention there was a question here that looked appropriate for you. With the number of issues concerning breaches and incidents, and they reference Anthem and Premier, there must be an even greater need in the industry to demonstrate stakeholder trust. What are ACOs, portals, and other networks doing to secure patient and provider data?
So that's an excellent question, and I think that what is happening, Dave, is that there are, as I indicated in my presentation, I think a number of organizations are becoming far more aware of the need to have third-party review. And so I think organizations are, in fact, contracting with whether it's accreditation, certification, audit firms to assist them in providing that level of review of all their policies, procedures, controls, the various network exchange points, and how organizations are authenticating and securing data as part of those exchanges. We're seeing that in relation to the ONC in their report that they went out with for their 10-year plan for interoperability. We're seeing it with EHI, the WEDI reports. All of them are focused on certification and accreditation and providing kind of that third-party review. So we see that as all being very important, and it's all about stakeholder trust and risk mitigation. So we've seen a significant increase, and I believe we'll see even more of an increase on an ongoing basis here of organizations wanting that third-party review.
Great, great.
So I think we're at bottom of the hour at 2:30, Dave.
That's right, just past the 60-minute mark. If there are additional questions, please feel free to reach out to us at EHNAC or at HealthEC. We're happy to answer those questions. I provided some contact information in this right on the screen there. So please reach out to us. We're happy to answer any of those additional questions you may have.
And please look for additional information on the next in the three-part webinar series. And we appreciate all of your attendance. Thank you.